Thank you, Nick. Our final speaker is Dr. Michael Connelly. Michael is an advanced trainee currently at Joondalup Hospital and soon to start his regional fellowship at Charlie's. Michael will be presenting his audit findings on adductor canal catheters versus single shot blocks from Hollywood Private Hospital. And actually the Hollywood APS team are here who are, I think, quite instrumental in helping to collate that data as well. So please welcome Michael.
All right. Good evening, everyone. Good evening, everyone. First of all, thank you to WASORA for inviting me to speak this evening. As Adam has said, my name is Michael Connelly. For those of you who don't know me, I'm an A2 at Joondalup at the moment, just rounding off the last 3 months of my training there before embarking on general and regional fellowships at Charlie's from August this year. I've got a lot of thanks to give for lots of people this evening, which I'll mention towards the end. But myself and David Robinson, who is a colleague of mine, who's a trauma fellow at Royal Perth at the moment, we conducted an audit looking at single-shot adductor canal blocks versus catheters at Hollywood in November of last year. And we chose November because November was a particularly high throughput of total knee arthroplasties in a given month over the year. It's big thanks to Chris Mitchell for linking us up to the Hollywood team. And in particular, very big thanks to Sinead O'Leary, who orchestrated the whole data collection perspective over at Hollywood. In particular the APS team and physiotherapy teams over there. That meant we were able to capture a lot of data for this within just a month. In discussions with the APS team over at Hollywood, it was noted that, anecdotally at least, that single shot blocks were potentially receiving more rescue blocks on the wards. And as a result, we wanted to have a look to see whether or not there was any difference in not only that, but also in whether there was any difference in rest pain, difference in pain or mobility, or any functional differences, as well as any differences in PRN analgesic requirements. This, by the way, is the poster presentation that we presented at for those of you who weren't at the ASM at the beginning of the month, or even those of you who were at the ASM, this is the poster. There were 150 of them, so I forgive you if you didn't see it. But this essentially summarizes everything that we found, which we'll go through this evening. So I was always taught with any presentation you should have a theme as well as a subject. So the subject is obviously single-shot adductor canal blocks versus catheters in total knee arthroplasty. But a subtle theme throughout this presentation is AI-generated images. It may seem like a random topic, but the reason I bring it up is because I think it's going to be entering a lot of our presentations more as time goes by. For those of you who are interested, Elon Musk recently did a 90-minute lecture on the New York Times Open Book Deal Summit. And he talked about the threat of AI and what it poses to us on a world scale. He feels that the risk is so high that within the next 3 years it will pose a significant risk to mankind, whether you believe Elon or not. But I think in healthcare we're probably relatively protected. For example, this is an image that was produced by ChatGPT on the standard patient undergoing a total knee arthroplasty. And as I'm sure you can see, it's not quite the standard. It also only has one leg for the more astute of you. But one of the benefits of these images in presentations like this in a public forum is that you actually retain copyright of any of these images, which can be a use. I think it's going to be something that will be something entering more of our presentations as time goes by. So what do we know about this already? There's a lot of data already out there in this sphere. And there's a lot of conflicting data in this sphere as well. So there's multiple meta-analyses of RCTs in this arena. And as I mentioned, a lot of it is conflicting, which I think has led to a lot of gray area in this arena. And a lot of very senior anaesthetists here who, all of you will know that there's lots of different factors that go into making a decision about one given technique. And a lot of those is hospital culture-based, as well as protocols that exist at a given hospital, the skill of nursing staff, as well as individual preference for a given technique. So I think there's a lot of influences. But what we do know is that inadequate analgesia following total knee arthroplasty does lead to prolonged hospital stays and increased risk of complications from an arthroplasty perspective. So what about looking at these studies briefly before we get on to the audit? So there have been, sorry, I'll just go back one slide. There have been multiple meta-analyses between 2020 and 2023, between 700 over 1,100 total knee arthroplasties. Crucially, all of these meta-analyses have looked at the 24 to 48 hour time point, which I think is really important when interpreting the audit data that we looked at. As I mentioned, they are conflicting, but most recently they showed there was no difference in pain severity or opioid consumption in the most recent and largest meta-analyses. But I'll remind you that they did look up to the 48-hour time point, whereas the audit that we looked at actually looked at the 72-hour time point, which I'll come on to shortly. So just very briefly, we'll look at each of these. In 2020, there was a trial including 739 patients, varying primary and secondary outcomes for each of these, so keep that in mind. But they concluded statistically significant better pain at rest and on mobilization with catheters with reduced need for rescue, which fits in with what our hypothesis may have been at Hollywood. And there was no difference in length of stay or in nausea or vomiting in those patient groups. Moving on to 2022, 910 patients, statistically significant better pain scores, and interestingly in quadriceps strength, but not actually in functional outcomes. Again, there was no difference noted in nausea, vomiting, length of stay, and nor in opioid consumption. The largest and most recent trial looked purely at rest pain and opioid consumption, but rather conflictingly found no difference, but I reiterate, up to the 48-hour time point. Interestingly, they also noted fewer complications with a single shot. So ultimately mixed data out there, but we wanted to, with this audit, exclude the impact of that initial block mixture, specifically any adjuncts that were used in that initial block mixture, so that we could compare more effectively each individual technique, which is why we looked up to the 72-hour time point. So what about your practice? I'm not under any illusions following this talk. I'm not expecting you all to go out and use catheters based on what I'm saying, but if I can give you a little bit more information about what's going on in the local sphere, then I'll have considered this talk a success. So what about our audit? So given the efforts, and thanks to the efforts of Sinead O'Leary, we were able to capture a lot of patients for 1 month of data collection, and also thanks to the physiotherapy and APS teams. And amongst that, we were able to capture 23 single shots, as well as 91 catheters that were done, reflecting the preference for catheters at Hollywood. And we wanted to include patients with minimal aberrancy of their physiology. So we wanted to have only primary total knee arthroplasties and excluded anyone with aberrant pain physiology. So anyone with a chronic pain history, anyone who'd used opioids within the last 90 days, and any surgeries other than primary elective surgery. So excluding things like trauma, bilateral surgery, revision surgery. Sorry, I'll just slide through those. So how did we actually do the data collection? So it began with patient enrollment and assessment by APS on day 1. That was merely to assess whether or not they were appropriate for inclusion into the audit. Physiotherapy evaluations on day 2 looked at knee range of motion. They also looked at distance mobilized, which is all part of their normal physiotherapy assessments. And we also asked them to look at and document location of pain in addition to what they normally would do. So whether that be anterior, medial, lateral, or posterior being the worst site of pain. And then APS follow-up on day 3 that recorded pain severity on a binary scale of 0 to 10. Numerical scale of 0 to 10. Pain location, again, was documented, as well as the number of PRN analgesics. And we just wanted total PRN analgesics, not dividing it down into individual different PRN analgesics, just to give a total number. So all in all, we had a recording of the pain levels on day 2 and day 3, pain location on the same, the quantity of PRN analgesics used, as well as a functional scoring by physiotherapists. So again, in keeping with our AI theme, this is a fully recovered total knee arthroplasty, apparently. What about the results? So we will look at each of these in turn. So the catheter group reported lower median pain scores while mobilizing compared to the catheter group. There was a difference of 4 out of 10 versus 5 out of 10. Clearly statistically significant, but whether or not that represents a clinically significant difference is still to be identified, which we'll come on to. But certainly there was lower pain scores from a statistically significant perspective whilst mobilizing. Fewer catheter patients reported anterior pain on day 2 and on day 3. Statistically significantly so. And interestingly, although I've not shown it on this slide, there was higher incidence of posterior pain with the catheter group, which presumably represents, this is actually the highest, the location of the most severe pain. So it presumably represents blockade of the saphenous nerve more anteriorly, and in the catheter group showing more posterior pain than single shot blocks. Interestingly, 100% of the single shot group experienced anterior pain on day 3, which is data that hasn't really been looked at in terms of the previous meta-analyses. And only 47% of the patients with catheters had anterior pain. All of the other parameters that we looked at all trended towards favoring catheters, other than distance mobilized. Distance mobilized was fairly equivocal between the two groups. However, pain at rest on day 2, the degrees of flexion between single shots and catheters, as well as the number of PRNs used, none of which were statistically significant, although all favored trending towards catheters, other than the fact that they didn't reach that normal 0.05 p-value that we all aim for. But trends were towards favoring all of those. So in summary of these findings, catheter groups experienced significantly lower pain scores whilst mobilizing. However, pain scores at rest were pretty comparable between the two groups. There was a significant reduction in anterior pain in the catheter groups on both days, day 2 and day 3. And in other categories, there were trends towards favoring catheters in degrees of flexion and in PRN analgesic use. Mobility distance mobilized was fairly equivocal between the two groups. So what does this mean? I think certainly within Hollywood, I think it makes a reasonable argument for using catheters over single shots, given the fact that I think if you were to propose to a patient that they would experience less anterior pain on mobile, or less anterior pain and less pain on mobilization, even if it weren't to make a functional difference, I think some patients would say that they would want a catheter. Not necessarily repeatable necessarily across all hospitals. As I mentioned at the start, there are all sorts of different factors that play into that. And whilst there is some statistically significant differences here, we haven't necessarily looked at whether something is clinically significant, which is part of what I think would be the next steps in looking into the future. So what about the future? I think given the meta-analyses that have been done and the most recent one has mentioned, the penultimate one has mentioned that there were an increase in block complication rates with the single shot group, I think a period of longer data collection, looking at the time period between 48 and 72 hours to see whether there was any difference which may add to the body of evidence that's out there for meta-analysis in the future. Looking at the incidence of rescue blocks, which interestingly, actually, we did start this project out to look at rescue blocks, but there wasn't a single rescue block in the whole month of November, which was just unfortunate, I think. So I think a longer data collection would capture some of that data and allow us to have a better idea of what's going on there. And I think getting a bit of an understanding of what clinical significance there was using patient satisfaction scores, but that element of things is difficult being so subjective. And finally, to round off the AI involvement of this talk, just to reassure some of the anaesthetists in the room who are worried about AI, this was an image of an adductor canal anatomy that AI spat out, and at first glance seems like an anatomically correct image, but you can quickly see it's all complete and utter nonsense. So my personal favorite is the adductor blondel. But yeah, there was a couple of images that it spat out that I think proves we've got nothing to worry about. So, I mean, I'd like to say a big thank you to Chris Mitchell for supervising this project and for introducing Dave and I to the Hollywood teams. I'd like to say a big thank to Dale Corrigan for helping us with the statistical side of things. Thanks to David, who is my partner in crime in doing this audit, as well as a very big thank you to Sinead, who, as I mentioned, orchestrated all of the data collection over at Hollywood, as well as the APS teams and physiotherapists who were instrumental in data collection. So thank you for listening and taking the time. I believe we've got some time for questions for everyone now. I think that's it.